Hello, Vaishali ma'am. Good evening. Hello.
आहे बसली आहे येऊन. आवाज येतोय का?
हो येतोय.
ओके ओके ओके. ते म्यूट ठेवते, आजूबाजूला खूप आवाज आहे.
ओके.
बसली आहे येऊन.
वैशाली मॅम, एक्सक्यूज मी. मॅम, आवाज येतोय माझा? हॅलो, वैशाली मॅम, आवाज येतोय? हॅलो कविता मॅम, गुड इव्हनिंग. आवाज येतोय का मॅम? हॅलो. Hello, madam. Not audible? Yes, ma'am, you are audible. Can't hear you. Hello. Can you listen to me? Can you hear me? Yes, ma'am. Yes. Okay, that's good. Varsha, here you are with me? Yes, 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 yes. Okay, fine. We'll be starting the meeting shortly. Dr. Asha is here, Dr. Varsha is here. Our speakers are with us.
Kavita, just raise your volume.
Okay, I will do that.
Yeah.
Is this audible?
Yeah, you are audible, but your voice is.
Madam,
Is this audible?
just give me 2 minutes.
Hello.
There's some issue with my internet connection. I'll just get back to you.
Okay.
Now is it, am I audible?
Yeah.
Yeah, you are audible, madam. Okay. We'll wait for another few minutes. Sure. Yeah. Varsha?
Yes, ma'am.
Can you make Dr. Sejal Suratkal as the co-host, please?
Yes, yes. Okay.
Because she is going to conduct the next for the few sessions.
Okay. Okay, ma'am.
That would be good. Shall we start the meeting now? It's 7 o'clock sharp, I think so.
Yes, we can start.
Good evening, everyone. Myself, Dr. Kavita Nivargi, President, Solapur Anaesthesiologist Society. Welcome you all for today's webinar on pain and pain management. Okay, sorry for the disturbance. Shall we start again? Good evening, everyone. Myself, Dr. Kavita Nivargi, President, Solapur Anaesthesiologist Society. Welcome you all for today's webinar on pain management and anesthesiologist. We, the anesthesiologists, have expanded our wings out of the operation theater from the conventional anesthesia to the very different other branches of anesthesia which are pertaining to anesthesiologist, and one of that is pain management. I'm grateful to have our speakers today, Dr. Varshali Kenia and Dr. Asha Barge, who have accepted our invitation to speak on certain chosen topic related to pain management. I'm grateful to MSc ISA, Dr. Manisha Katikar, President MSc ISA, and Dr. Avinash Bhosle, Secretary MSc ISA, for providing us this Zoom platform to conduct this webinar. I would like to thank Mr. Akhilesh Kulkarni from Geneka, who have given us a good technical support till now. And now Varsha is going to be with us for this meeting. Now I would ask my clinical secretary, Dr. Sejal Suratkal, to introduce our speakers and start the session further. Over to you, Sejal. Unmute yourself, Sejal, first. Yeah.
Thank you, Nivargi madam.
One sec,
We are
Sejal.
start. Hello.
Varsha, can you please put on the slide of CV of Dr. Vaishali Kenia? When,
Okay. Yeah.
Over to you, Sejal, now. Thank you.
Thank you, madam. So first lecture is preemptive to preventive analgesia by Dr. Varshali Kenia madam. Madam is working as a professor at Bharati Vidyapit Medical College and Bharati Hospital, Pune. She has 20 plus years of experience in the field of anesthesia with special interest in regional anesthesia. She is working as a pain and palliative care physician at Bharati Hospital, has taken a lead role in starting acute pain services at Bharati Hospital. She has worked as a secretary of Society for Study of Pain, Pune, and as a faculty for USG guided block workshops and conferences. Madam has nearly 8 publications in pain and palliative care. She is an active member of Indian Society of Anesthesia, Indian Society for Study of Pain, and Association of Regional Anesthesia. Over to you, madam.
Thank you, Sejal, for the kind introduction. Yeah. Can I share my screen, please? Yeah. Can everybody see my screen? Is my screen visible
Yes,
to
yes,
all?
ma'am.
Yes, ma'am.
Yes,
Yes.
Yeah. Yeah. Okay. Good evening, everybody, and warm greetings from Bharati Hospital and Bharati Vidyapit Medical College, Pune. Before starting the talk, at the outset, let me thank the office bearers of Maharashtra State ISA, Maharashtra State Society ISA and Solapur City Branch ISA for giving me opportunity to talk on a very important topic, and the topic which is very close to my heart, on the chronic pain. While searching for deciding the topic, on which topic amongst the very vast topic of chronic pain, which one to talk, I came across a very good or very interesting terminology, preventive analgesia. And then so I decided to talk on that. So let's see, and hope this topic interests everybody. Yeah, as we all know that as a practicing anesthesiologist, our main aim is to give balanced anesthesia with the help of hypnosis, amnesia, muscle relaxation, and analgesia by using various drugs and techniques that are available to us. So the important aspect of a balanced anesthesia with other things, the analgesia plays a very important role. Now, with the advancement in the medical research, we try to give our patients a very optimal situations perioperatively by using various drugs available and techniques available in the anesthesia armamentarium so as to have a favorable outcome with greater mobility, wound healing, fast wound healing, and patient satisfaction. And so we try to provide the analgesia or perioperative analgesia by attempting to give preemptive analgesia. And with the inclusion of the pain as a fifth vital sign, this has gained more importance in recent years. So the preemptive analgesia is the analgesia or the medications given just before the surgical incision, considering that the incision itself is a causative factor or the main important factor to have a post-operative pain. And that's the reason we try to include all the drugs or techniques just before the incision, and we try to catch that particular point. Okay, before incision, we will give the drugs and have a good post-operative care, considering that it will block the central neural sensitization and reduce the post-operative pain intensity. So the anti-nociception, according to the previous theory, starts before the noxious stimulus, considering it will prevent central sensitization, decrease intensity of the post-operative pain, decrease hyperalgesia, and have a favorable outcome post-operatively. But is that so? With the recent studies and multiple RCTs and systematic reviews, this is being really questioned. Let's see how. The preemptive analgesia has been refined over the years and evolved to a broader concept. Because as with the research, only the incision or the surgical incision is not the only triggering factor to have a post-operative or perioperative pain as well as post-operative discomfort. So with the research in the updated review by Moynier in the Anaesthesiology in 2002, what he did was he considered 80 trials and he divided those studies or those papers into various subgroups according to the drugs given for the during perioperatively, analgesic drug given perioperatively, and he tried to find out that really the drugs given pre-surgery or pre-incision help to have a control on the post-operative pain, and overall finding was negative to that. Similarly, Cliff et al. Also searched in his randomized control trials and compared various interventions in 66 studies ranging in around 3,000 patients, which also concluded that the post-operative pain scores were not improved very much. But why really we are worried about the perioperative pain control or especially the post-operative pain control? Crombie in his paper presented that when in his chronic pain clinic, he came across around 22% of the patients who had chronic pain because of the surgery, while the trauma was a lesser cause for a patient having chronic pain. So this is really alarming. Similarly, in 2017, International Society for Study of Pain announced that year as a global year against pain after surgery. So definitely, this is alarming. So any pain untreated or less treated perioperatively can lead to chronic post-surgical pain. And most of the patients post-surgically do well, they go home and there is no after effects of the surgery or the pain. But definitely the post-surgical pain is increasing, and it is alarming and a neglected topic. It also reduces the quality of the life of the patient and contributes to an economic burden of a chronic pain. But very important point highlighted here is the chronic pain was once upon a time acute pain. And as surgery, as the surgical conditions presents us to circumstances which are predictable, and precise timing of the physical insult and ensuing pain are known in advance. And we should take this opportunity to treat those factors rather than aiming at giving the analgesic just before the incision. So when we say that the pain is chronic pain or chronic post-surgical persistent pain or PPP, post-surgical persistent pain. So in his paper, Joel Clark mentioned the definition by McCree and Davis that it's a 4-point definition, that if we can designate the pain as a chronic post-surgical pain, when the pain is developed after the surgical procedure, the pain is at least 2 months of duration. Other causes of the pain have been excluded, and the possibility that the pain is continuing from a pre-existing problem should be explored and exclusion attempted. Before venturing out into preemptive to preventive pain, let's have a look in short about the brain transmission. I won't take much of a time, or I won't go in at the molecular level, just an overview of the pain transmission and why we have to shift from now preemptive to preventive analgesia. So the understanding of primary or peripheral and sensory sensitization is must. So how the pain is transported to the brain, or how it is transmitted. So nociceptors are the nerve endings of the A delta and C nerve fibers which are present in the periphery. Any injury leads to secretion of all the inflammatory mediators like potassium, protons, nerve growth factor, tumor necrotic factor, histamine, interleukins. These inflammatory mediators stimulate the nociceptors, and this is conducted through the A delta and C fibers in the form which are stimulated and action potentially generated, and which are conducted towards the center in the dorsal root horn of the spinal cord. At the dorsal root horn, they communicate with the second order neurons, which then transmit the pain signals to the thalamus. From the thalamus, the third order neurons, they transmit the pain signals to various central areas like sensory cortex, limbic nuclei, reticular formation, and periaqueductal gray matter. So this is how the pain is transmitted from periphery to the central area of the brain. Now this periaqueductal gray area plays a very important role in modulation of the pain, from where the descending pathways descend to the dorsal horn and give a negative feedback so as to limit the pain transmission to the central area. This is how any normal pain is transmitted to the central nervous system. But is that so always? What happens when the pain becomes repeated or chronic? So what happens with the repeated stimulation of the peripheral nervous system? Certain mediators are secreted, and these mediators give repeated stimulation, like the mediators like interleukin 1b, interleukin 6, nerve growth factor, TNF alpha. They induce the histamine release from the surrounding mast cell. Now this histamine release stimulates the C fibers continuously. So the transmission from the C fibers, or there is a bombardment of the stimulation from the C fibers to the dorsal horn. And this is known as a neurogenic inflammation, and which is resultant cause of peripheral sensitization. And the peripheral system is always in a hyperexcitable neuronal state. So this is primary or peripheral sensitization. Coming to secondary or central sensitization. Because these C fibers and A delta fibers are continuously stimulating there is increased secretion of the glutamate as well as the substance P. This glutamate at the dorsal horn has an important function to stimulate or get attached to NMDA receptors and stimulate those NMDA receptors. And this allows subsequent stimulation of the wide dynamic range of fibers in the dorsal horn. Now, these wide dynamic range of fibers are stimulated by C fibers, A delta fibers, as well as A beta fibers, which are actually non-pain conducting fibers. With this, because of the repeated stimulation and NMDA receptor activation, these non-pain conducting fibers can also get stimulated, which in turn may cause perception of the impulses like touch to have a feeling of pain, so causing allodynia. That is because of the sensory secondary sensitization or central sensitization. Also, there is activation of the cyclooxygenase, especially the COX-2, which increase the prostaglandin secretion at the level of the dorsal horn as well as the level of the periphery. These prostaglandin per se themselves do not cause any pain, but they do sensitize the dorsal horn and causes increase in the stimulation and lead to secondary hyperalgesia. So, as explained, increase in the release of arachidonic acid or COX-2 activation, increase in the prostaglandin synthesis leading to peripheral or primary sensitization, while activation of the NMDA receptors at the central area and increase in the production of prostaglandin lead to the secondary hyperalgesia or central sensitization. Now, to understand the changeover from preemptive to preventive analgesia, let's see what Joel Katz has mentioned in his review article. To make the thing simpler, what he has done, he had represented a schematic diagram with various options to give analgesia preoperatively, intraoperatively, or postoperatively. And according to him, there are almost 8 options the way you can try to give analgesia. As well as he identified the causes which can cause pain preoperatively, which could be genetic, psychological, environmental or noxious inputs, and preoperative pain, which are very different from the intraoperative, which could be again cutting of the skin, fascia, muscle tendons, nerves, etc. And postoperatively, because of the regeneration of the wound tissues, which mainly involves the inflammatory process. So in his first model, this is a classic example when we give the preemptive analgesia. So he studied around few studies which had given a preemptive analgesia and observed the postoperative pain intensity of the patient. What he observed that only giving in the group 1, when the patient received only pre-incision preemptive analgesia, the pain intensity and analgesia use decreased up to 48 hours, but did not have any impact in the post-operative or long-term benefit for the pain control. Second option is preoperative epidural as well as intraoperative and post-operative, where he observed that the pain decreased post-operatively, but again, beyond 48 hours or after that, the pain control was not that significant. But yes, he compared with the saline. With the saline, those were better, but not after 48 hours. Now, this is the classic example when we say that we have preemptive analgesia as well as intraoperative and postoperative analgesia. What he mentioned a study by Fasalaki, where he had given preoperatively gabapentin, intraoperatively ropivacaine to the brachial plexus and intercostal nerves, and postoperatively emla cream on the incision site in a patients who were undergoing breast surgery. a very important finding he observed. After say 3 months, the pain in the axilla, arm pain, and analgesic use were significantly reduced as compared to other group where none of these agents were given, where the pain in axilla, arm pain, and analgesic use was tremendous. So this indicates not only preemptive, but intraoperative and postoperative intervention with respect to pain control is necessary. And second very important point, the mode of giving analgesia. At every intervention, the mode is different. So this was very important observation. So to revise, we have certain identified factors for preoperative pain, for intraoperative pain, and postoperative pain, which are very different from each other. And we need to target these factors perioperatively so as to have a better postoperative pain control. So, coming to preventive analgesia, how can we achieve? So, we should aim to give preemptive analgesia at each of the timeline before incision, surgery, and postoperative. So, this comes under the preventive analgesia. We are preventing by giving preemptive analgesia at various stages by identifying the various factors which can lead to postoperative or long-term pain, and thus controlling long-term pain or overall outcome of the patient. So in general, the duration of the analgesic drug should be longer than its preemptive target. So giving preemptive analgesia at all the throughout the surgery or perioperatively will definitely block the central neural sensitization. So to summarize, so preemptive analgesia is that is initiated before the surgery, and it prevents the establishment of the central sensitization, which is resulting only from the incision injury. And now we are very clear that it is not taking any attempt to prevent the sensitization which are occurring because of the other factors. So limited effect of sensitization, and it is due to the analgesic effect of the drugs because it doesn't have a complete effect to prevent the central sensitization. Whereas preventive analgesia is not on the relative timing of giving the analgesic, but it is attenuating the impact of peripheral nociceptive bombardment, which is associated with the noxious preoperative, intraoperative, and postoperative stimulus. And these observed effects are not only the analgesic effect. So it is demonstrated when we will say that preventive analgesia is effective when it is demonstrated that postoperative pain or analgesic use are reduced beyond the clinical duration of the action of the target agent, which we have defined as a 5.5 half-lives of the target agent. So it is a broader definition and more inclusive term, which any analgesic regimen in the perioperative period given to control the sensitization induced by pain. So what is our target period? Preoperatively, days before the surgery and minutes before the skin incision. And so the important role of on-arrival blocks and analgesics as soon as the patient arrives or sees any physician. Intraoperatively, after the incision, to those initiated just prior to the end of the surgery. And of course, postoperatively after the end of the surgery. And it extends for the days thereafter. Joel Katz is the scientist or researcher who has done extensive research and in the preventive aspect of the analgesia. What he has done, he had done a systematic review of various studies and seen the effects of various drugs depending upon their timing and whether it has a preventive effect in the form of positive or negative, or it had a no effect. Because he had considered all various factors at all the three timelines: preoperative, intraoperative and postoperative. So now what is the clinical implications, or how do we apply in our clinical setup? Coming to one by one all the drugs, what we are using daily. We are fortunate enough to have an armamentarium of various drugs and techniques. Only thing is we have to understand when to use, what to use, and how to use, and on what it is acting. So if we have a good understanding of that, definitely we will have a favorable outcome for our patients with minimal or no postoperative pain. So let's see one by one all the drugs. Coming to NMDA receptor antagonist, what McCartney et al. Has observed that ketamine, it being a NMDA receptor antagonist, plays a very important role in prevention of the central sensitization. And he observed in his studies that it reduced greatest number of, it has a significant preemptive or preventive effect. It is almost 58%. Now, ketamine blocks the neural process underlying the central sensitization and also attenuates the development of acute opioid tolerance. This is very important because opioid, after a certain time, it gives a tolerance, but it attenuates the development of acute opioid tolerance, and it reverses the opioid-induced facilitation of the nociceptive processing. So ketamine, a very important drug to prevent the central sensitization. The usual dose given is 0.15 in a bolus form, or continued with the infusion perioperatively as well as postoperatively. The second important group of drugs that are used to prevent the central sensitization is gabapentinoids, pre-GABA and gabapentin. Gabapentin binds to the alpha-2 delta subunit of voltage-dependent calcium channels, and it also acts at the GABA receptors. They are described as an anti-hyperalgesic, and they have a robust opioid sparing and pain relieving effect in acute post-op period. So similar study conducted by Fusalaki, he observed that the requirement of opioid was decreased post-operatively, and there was reduction in the neuropathic pain 3 months after surgery. NSAIDs, again, very important drugs in anesthesia armamentarium. Now, how to understand how NSAID acts? In one of the study by Samad, what he said that the pain transmission occurs in 2 ways. What we have seen is a classic way, that is neurally mediated or electrically mediated transmission through the nervous system. But there is one more transmission of the pain feeling or pain sensation, which is non-neurally, in which a humoral signaling molecules which are originating in the inflamed tissue, they act on the central nervous system via bloodstream, and where they produce ample amount of cyclooxygenase 2 in the central nervous system. Now, this cyclooxygenase 2 is responsible for production of prostaglandins, which sensitize as we have seen in the secondary sensitization, the prostaglandin play an important role in secondary sensitization. So NSAIDs, by action on the COX-2, inhibition of the COX-2, they have a very important role in prevention of the chronic postoperative pain. They have a longer half-life, and they block the inflammatory response for a longer duration. Local anesthetics, as we all know, they have anti-inflammatory properties, which may also decrease the sensitization. They may reduce ectopic firing of the neurons and reduce the expression of the cytokines and other inflammatory mediators. There are multiple studies which indicate that local anesthetics in the form of either local infiltration, IV, or in the epidural or central neuraxial axis has a very important role in prevention of the chronic postoperative pain. Coming to opioids, these opioids have a mixed action. various studies have shown contradictory result. Naturally, the opioid themselves cause because they themselves cause central sensitization and cause opioid-induced hyperalgesia. So what literature recommends that because of the activation of NMDA receptors and protein kinase, which leads to activation of the facilitatory supraspinal loops, is responsible for opioid-induced hyperalgesia, and this can be prevented by application of NMDA receptor antagonist such as ketamine. So ketamine has an important role and are suggested to use along with the opioid to prevent opioid-induced hyperalgesia. But at the same time, few of the studies mention that it can cause reversal of the central sensitization by interfering with the intracellular calcium level in a complex way. So we have to, so it's like a double-edged sword. So we have to use opioids in a controlled manner. Coming to alpha-2 agonist, a favorite drugs nowadays of everybody, clonidine and dexmedetomidine. The alpha-2 agonists act centrally as well as peripherally, and they cause sympathetic inhibition, as we all know. There are not much studies about their role in prevention of the chronic postoperative pain. So many more studies are recommended. But definitely they can be used very well in perioperatively. Yes, regional anesthesia. A very interesting topic and very important as a part of a multimodal analgesia. Now we all know that they block nociceptive nerve impulses and regulate the signal from the glial cells. And so they reduce the central sensitization or secondary sensitization. Also, the local anesthetic, they themselves have anti-inflammatory properties, which may also decrease the sensitization. So this is important aspect of a multimodal analgesia. The very in-term multimodal regimen. So everywhere now there is a talk about the multimodal regimen, and multiple studies have mentioned the positive effect of multimodal regimen, in which the 3 or more agents in combination are used. These different analgesic medications or techniques simultaneously target the multiple receptors within the nociceptive and neuropathic pathway, which can be taken advantage of. So, coming to the end of my talk, what is the take-home message? One important aspect, current pain predicts the future pain. Preventive analgesia is not time constrained and involves the use of analgesic interventions perioperatively, taking into consideration the various factors which lead to perioperative pain or stimulation of the nociceptions throughout surgery. The duration and efficacy of the perioperative analgesic regimen is more important than the preoperative timing of the analgesic intervention alone. So, preventive analgesia, a broader definition and more inclusive term, which encompasses analgesic regimen in perioperative period to control the sensitization. So, suppose we don't have a time to give block or epidural, but whenever the opportunity is given, the preventive analgesia can be applied in any form. Effective multimodal analgesia is an important component of preventive analgesia, resulting in an increased duration of action of analgesic drugs to decrease long-term pain sensitivity. Without a proper pain management plan, postoperative pain has a potential to result in chronic pain. And we as an anesthesiologist should not be a part of that. Lastly, prevention of the pain has been dubbed as a holy grail of anesthesiology. Something that you want very much, but that is very hard to gain. That is actually the meaning of Holy Grail. It was the cup that was used by Jesus Christ, and that was sought by the various kings during the Middle Ages. So it appealed to me a lot. The prevention of the pain has been dubbed as the holy grail of anesthesiology. Welcome for any questions. Thank you.
Thank you, Dr. Varshali Kenia, madam. The discussion session will be at the end of second lecture. So we are moving ahead with a second topic, that is common interventions and role of anesthesiologist in pain management by Dr. Asha Barge. Let me introduce her in Dr. Asha Barge madam is working as a director at Barge Pain Clinic and Mangalmurthy Hospital. She is also working in Department of Pain Management, Mangalmurthy Orthopedic Hospital. Yes, madam.
Varsha, can you put up the slide of CV, please, Dr. Asha?
Yes, ma'am.
I have, madam. I have it with me.
No, she'll put up on the screen, please.
Fine. Dr. Asha Barge madam is working in Department of Pain Management at Mangalmurthy Orthopedic Hospital, Oncolike Hospital, and Satara Hospital at Satara. She is practicing anesthesiology since 1996. She has started her own Barge Pain Clinic in 2011. She has completed her postgraduate diploma in medico-legal sciences too. She is a fellow of Indian Academy of Pain Medicine. She is also a fellow of SLF Academy of Pain. She has done her fellowship in ultrasound guided interventions in chronic pain. She has recently passed a national fellowship examination of Indian Academy of Pain Medicine. She has articles published in Indian Journal of Pain and in Journal of Evolution of Medical and Dental Sciences, and also in MISA News. She is a faculty and guest speaker in various national and international conferences. Over to you, Dr. Asha Barge, madam.
Let me share my screen. Is my screen visible to everybody?
Yes, madam.
Yes, ma'am.
And I'm audible, everyone?
Yes,
madam.
Yeah. Good evening, everyone. Today is World Cancer Day, and I'm really thankful to my Maharashtra chapter ISA and Solapur ISA Society, Dr. Manisha Katikar madam, my friend Dr. Kavita Nivargi, who she is president, and Dr. Vaishali Yemul, she is secretary, and whole Solapur Society for giving me the opportunity to talk on chronic pain. So my friend Varshali has covered very nicely how to prevent chronic post-surgical pain. And she has also very nicely covered physiology of pain and pathophysiology of chronic pain, the peripheral sensitization and central sensitization. Chronic post-surgical pain is one entity under chronic pain. Actually, the management of chronic pain is very vast topic, and it's difficult, rather impossible to cover all the things at one time. Still, I will try to cover most of the aspects regarding chronic pain. So let us move to today's topic. My topic is common interventions and role of anesthesiologists in pain management. Pain is considered as fifth vital sign, and chronic pain is a disease, a syndrome, and not just a symptom. The International Association for Study of Pain has revised definition of pain on 16 July 2020, and the definition is: pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage, and is expanded upon by the addition of 6 keynotes and etymology of word pain for further valuable context. The keynotes are: pain is always a personal experience, and that is influenced to varying degrees by biological, psychological, and social factors. Pain and nociception, they are different phenomena. Pain cannot be inferred solely from activity in sensory neurons. Through their own life experiences, individuals learn the concept of pain. The person who reports pain should be respected. Although pain usually serves an adaptive role, it may have adverse effect on function and social and psychological well-being of the patient. And verbal description is only one of the several behaviors to express pain. Inability to communicate does not negate the possibility that a human or non-human animal experiences the pain. Types of pain, the pain can be divided into acute pain, chronic pain, and malignant pain. Chronic pain is again divided into nociceptive pain and non-nociceptive pain. The nociceptive pain, the conditions are postoperative pain, arthritis, mechanical low back pain, ischemia, infection, trauma, and neuropathic pain such as post-herpetic neuralgia, complex regional pain syndrome, trigeminal neuralgia, etc. The structure of ISP classification of chronic pain, according to it, the chronic pain is divided into chronic primary pain and chronic secondary pain. There are 7 main categories of chronic pain according to ISP. Chronic primary pain, chronic cancer-related pain, chronic post-surgical and post-traumatic pain, chronic neuropathic pain, chronic secondary headache or orofacial pain, chronic secondary visceral pain, chronic secondary musculoskeletal pain. Those who are interested in detailed classification, they can refer to this article. Chronic pain has various effects on human body, some physiological effects and psychological effects. The psychological effects make the patient becomes depressed. It limits the activity of the patient and thus affects the family income. The personal, family, and social life is disturbed. There is loss of self-confidence. There can be sleep disturbances also. So let us move to pain management specialty. It is a new specialty of medicine. Pain management is a super specialty branch of conventional allopathic medicine. Pain physician is a specialist who assesses and evaluates pain, classifies and grades it, and then treats it effectively. Pain medicine is a specialty area of anesthesiologists, but nowadays it is open to neurosurgeons, orthopedic surgeons, rehabilitation medicine, and so on. Imaging techniques have become a part of this branch, and most of the procedures are US FDA approved. Pain clinic is a comprehensive multidisciplinary pain management center. The concept of pain clinic is well-coordinated effort of specialists possessing knowledge and skills to diagnose and treat pain. They simultaneously treat the physical, emotional, cognitive, behavioral, vocational, and social aspect of chronic pain cost effectively. They use the knowledge and services of the specialties such as anesthesiology, neurology, radiology, psychology, physical therapy, orthopedics, and neurosurgery. Why anesthesiologists as a pain physician? Anesthesiologists are well versed with the art and science of treating pain. Their role as a pain physician is a natural extension of their professional work, and pain management is a part of their competence. They have better understanding of pain pathways and related pathophysiology. They are working with various analgesic drugs like opioids, non-opioids, local anesthetics, etc. So they have better knowledge of pharmacology. They have been trained in various regional blocks, centrally, peripherally. They are highly skilled and masters in CPR. And if we don't want to do it, somebody else will do it. The qualities to be a pain physician: anesthesia background should be used wisely. To be a successful, you have to be a good listener and clear to communicate to the patient. Be like counselor. Pre, during, and post-treatment is most important. Compassionate and sincere approach is very important. Give patient a feel that you are there to listen and treat him. Chronic pain patients could be difficult, but history is most important. Think of common problem first, think of simple treatment first, and think of available resources first. If needed, you can ask for help. Pain management targets. Pain management is not only putting needles, it is complete assessment and comprehensive treatment approach is desirable for patients' physical and mental health and pain control. Remember, you will be the brand ambassador of pain specialty, and your act reflects a specialty act. Our ultimate goal is to cure and care for people suffering from pain and make them productive human beings for society and increase their self-esteem so that they can live life as normal individuals. In order to treat something, we first must learn to recognize it. And to recognize, we have to understand in detail the physiology, pathophysiology of pain, which has been very well discussed with us by Dr. Vaishali. So let us not go in detail. We have to just remember the terminologies: transduction, transmission, modulation, perception, peripheral sensitization, and central sensitization. Now, once we have understood the everything physiology, pathophysiology, we have to assess the pain. And for assessment of the pain, we have to ask important questions such as how severe is the pain, what type of pain, are there other factors, are there any temporal characters of a pain present. For assessment of the pain, there are various scales available, and visual analog scale is most commonly used scale. There are numbers from 0 to 100 for rating the pain. Ask the patient to show what is his or her pain on the scale from 0 to 10. 0 is no pain, 4, 5, 6 is moderate pain, 8, 9, 10 is worst possible pain. This is Wong-Baker's faces pain rating scale. The smiling face is no hurt. This is hurt little bit. And the crying faces hurts the worst. History of the pain patient is very important. Always note down pain score was from 0 to 100. For treating chronic pain, always ask important questions like duration of pain, type of pain, aggravating relieving factors, whether the pain is referred. It helps in diagnosis and differentiates nociceptive pain from neuropathic pain. Examination is also very important. It includes inspection, palpation. Various tests could be specific to pathology like SLR. Thus, detailed history taking, clinical examination, and eliciting different clinical tests and signs can lead us to definitive clinical diagnosis. Reformation is very important for offering the treatment to the chronic patients. Chronic pain patients, we have to reform our knowledge of anatomy, physiology of nervous system, clinical medicine, pharmacology, neurology, orthopedics. We have to improve knowledge in radiology. When patient comes to us, we should be able to read an X-ray of spine, knee, shoulder. We should be able to read an MRI of spine. We should be able to differentiate T1 weighted images, T2 weighted images. We should be well versed with sonoanatomy, fluoroanatomy of all the structures. Now, once we have learned and have good anatomical knowledge, fluoroanatomy knowledge, and we have understood the relationship of bony structures and other structures, we can always prevent and manage all the complications involved or due to the interventions. The common intervention procedures in a pain clinic, they can be common pain syndromes in a pain clinic. They are low back pain, sciatica, radicular pain, neck pain, headache, knee and shoulder pain, trigeminal neuralgia, post-neuralgia, phantom limb pain, myofascial pain syndromes, cancer pain, regional pain syndrome, peripheral vascular diseases, diabetic neuropathy, etc. As said by Vaishali, the treatment philosophy is we have to offer the multimodal treatment, interdisciplinary approach, and
Slides are not moving.
Yes.
Yeah, slides are not moving.
We can't even hear Dr. Asha. So, Vasha, can you please look into this matter?
It suddenly stopped. Huh?
Yes. Hello, Varsha.
Yes, ma'am.
We can't hear Dr. Asha, and the slides are also not visible. Can you please look into this?
Ma'am, I think it's the internet issue.
Kavita, please call up Asha
Yeah, I'll do that.
and ask her to make it full screen. कारण ते तिच्या स्क्रीन फुल स्क्रीन झालेल्या नव्हत्या स्लाइड्स, त्यामुळे वाचायला कठीण जात होत्या.
Okay, I'll just talk to her.
अशा तुझं इंटरनेटचं काहीतरी अशा इश्यू आहे, जरा बघतेस? हा, ओके, शुअर.
Talk to her, and she's rejoining.
Ma'am, unmute yourself.
Tell her to show the slides in full screen. Slides in full screen.
Yeah. हा. बघ आता आलं आणि आवाज येतोय माझा?
मॅम,
Yes, ma'am.
तुमचा आवाज येतोय, बट स्लाइड हाफच दिसतीये. म्हणजे ते स्लाइडला डबल क्लिक करता का?
हाफ दिसतीये का?
नाही, इट इज ओके.
No, it is okay.
इट इज ओके नाउ. इट इज ओके नाउ.
We
Yeah.
can see it.
It's okay.
Asha, please go ahead. Asha.
Yeah. So the common drugs used in a pain clinic, they are acetaminophen, ibuprofen, naproxen, ketorolac, pregabalin. These are anticonvulsants, and along with these anticonvulsants, we mostly use antidepressants like amitriptyline, nortriptyline, local anesthetic drugs, steroids, acetyl salicylic acid, morphine, fentanyl, etc. This is a modified three-stage pain management ladder pattern. And with the invention or development of interventional therapies, we can introduce our interventional techniques early in this step ladder pattern. So what is interventional pain management? Interventional pain management, it utilizes the interventional minimally invasive techniques in outpatient setting in managing subacute, chronic, persistent, and intractable pain independently or in conjunction with other modalities of treatment. This is means we can divide the interventional procedures according to the risk involved: low risk procedures, intermediate risk, and high risk. The common interventions which are performed in a pain clinic, they are selective nerve root block, quadral epidural injection, cervical epidural adhesiolisis, facet joint procedures, then hip joint ganglion implant block, piriformis injection, sacroiliac joint injection, knee joint injections, platelet-rich plasma, genicular nerve block, then shoulder joint injection, suprascapular nerve block, TM joint injection, trigeminal neuralgia. For trigeminal neuralgia, you can perform supraorbital or supratrochlear nerve block, mandibular or maxillary nerve block, and RF lesioning of stellate ganglion, lumbar sympathectomy, trigeminal neurectomy, and superior hypogastric plexus block. In pain clinic, the most common patients which we encounter are patients of low back pain. And the major causes of low back pain, they are facet joint pain, discogenic pain, nerve root irritation, sacroiliac joint pain, and piriformis syndrome. All these causes, they cannot be diagnosed with X-ray or CT or MRI or other conventional tests in most of the cases, and we need to do some diagnostic procedures. Before going to some interventional diagnostic procedure, we have to understand the fluoroanatomy of the lumbar spine, and we have to understand the different parts of the vertebral body in a fluoro image. So interventional pain procedures, they can be divided in different two categories: the diagnostic procedures and therapeutic procedures. Diagnostic procedures are diagnostic facet joint block, provocative discography, epidurogram, spinal endoscopy, selective root block, SI joint block, sympathetic nerve block, differential spinal epidural block. And therapeutic procedures can be epidural steroid injection, selective root block, lumbar sympathetic block, medial branch block, trigger point injection, and SI joint injection. Now, before we take the patient to OT for the procedure, we have to understand our target areas for different procedures. Like for medial branch block, we have to target the superior at the junction of superior articular process and the transverse process. For transforaminal epidural injection, we have to target the intervertebral foramina. Likewise, for discography, we have to target the superior surface of the vertebral body. For lumbar sympathetic, we have to target the anterolateral surface of the vertebral body. All these interventional procedures, they are mostly performed under fluoro guidance or under the SIAM guidance. You can use ultrasound also, or you can use both the modalities together. This is a image showing transforaminal epidural block. This is an AP image and this is lateral image. In AP image, this is an exiting nerve root, and we have injected the dye, iohexol dye, and this is after injecting the dye, the nerve root is clearly visible. In lateral image, this is a needle which has entered the intervertebral foramina in the superior aspect. This is a image showing caudal epidural injection. This is an inverted Christmas tree appearance after the dye injection, and this is a needle entering the caudal epidural. This is a lateral image of caudal epidural injection. This is a caudal epidural space, and this is a needle entering the caudal epidural space. Management of failed back surgery syndrome. Now we don't call it as a failed back. We can call it as post back surgery syndrome. And this is a normal epidurogram. Means this is a diagnostic test to find out the adhesions in the epidural space. This is a normal epidurogram showing inverted Christmas tree appearance after putting the dye. And this is a filling defect in post back surgery syndrome after putting the dye. And in the management of post back surgery syndrome, we can manage the patient by giving different drugs, or we can do epidural adhesiolysis. We can give sympathetic block or facet joint block, and the spinal cord stimulation is the last option. Sacroiliac joint arthropathy is another cause for low back pain. It is a diarthrodial joint. Ventral one-third is true synovial, and dorsal part is ligamentous. Synovial part is more prominent caudally. It is 100% synovial at S3 level. So we perform the sacroiliac joint injection at lower level. And this is a patient where we are doing Faber's test, flexion, abduction, and external rotation, which may cause pain in case of sacroiliac joint arthropathy. These are again images showing sacroiliac joint injection. This is a needle entering the sacroiliac joint in the lower part. Infection, inflammation, degeneration, traumatic, metabolic causes, malignancy, iatrogenic, post-pregnancy, all these can cause sacroiliac joint dysfunction. Facet joint, the facet joint is a potential source of pain, and in our practice, facet joint intervention is the second most common intervention next to epidural. So there are different facet joint dysfunction tests. Flexion of the spine causes opening of the facet joint, and extension causes closing of the facet joint. Lumbar facet joints open on the right side with left lateral flexion and left rotation, and lumbar facet joint close on right side with right lateral flexion and right rotation. This is a picture showing the facet joint which is inflamed and causing pain. The best way to diagnose the facet joint pain is a diagnostic block. This is an image showing a diagnostic block, and we have to target at the junction of superior articular process and the transverse process. This is a Scotty dog image in the fluoroanatomy of lumbar spine vertebra. The etiology of the facet joint arthropathy, it can be due to osteoarthritis, inflammatory arthritis, intrafacetal synovial cyst, or trauma. The next cause for low back pain is piriformis syndrome. The neuritis of the branches of sciatic nerve caused by pressure of an injured or irritated piriformis muscle. 0.33% of all cases of low back pain and 6% of all cases of low back pain and or sciatica, they cause piriformis syndrome. Piriformis syndrome, for piriformis syndrome, we have to perform piriformis injection. The patient is lying prone, and we have to target the midpoint of greater trochanter and sacrum, roughly above the head of the femur and acetabulum. And dye spread is seen along the piriformis muscle fibers, and local anesthetic with steroid is given. Radiofrequency techniques in pain management. These are the different machines available in the market: Neurotherm, Cosman. The principle of radiofrequency lesioning involves passage of a very high frequency current through a 27 gauge thermocouple probe. This probe is passed through a 20 or 22 gauge cannula, which is insulated except this tip. When a high frequency alternating current is passed, the charged ions move to and fro, and due to this electrical and mechanical friction, heat is generated. In the conventional type, we are producing heat lesion. We can go up to 85 degrees Celsius. In pulse radiofrequency, electrical field is producing the lesion. In pulse radiofrequency, temperature is not raised beyond 42 degrees Celsius. Electrical field produces some punch in the capacitor of small diameter nociceptive fibers, and thereby signal transmission is stopped. In the conventional type of the nerves are regenerated in future, and average pain-free period varies for the type of nerve, and in a properly performed lesion, pain-free period is 3 to 4 years, and in pulse radiofrequency, nerve is repaired, average pain-free period is 4 to 24 months. The sympathetic blocks in chronic pain are spinopalatine, stellate ganglion block, T2, T3, that is thoracic sympathetic block, splanchnic block, superior hypogastric plexus block, ganglion impar block. Spinopalatine block, the spinopalatine ganglion lies in pterygopalatine fossa, which is shown here as an inverted vas appearance. And the indications for a spinopalatine block are spinopalatine neuralgia, trigeminal neuralgia, headaches like migraine or cluster headache, atypical facial pain, herpes zoster ophthalmicus. The stellate ganglion block. The stellate ganglion is formed by the fusion of inferior cervical and first thoracic ganglia and lies between C7 and T1, 2 to T1 in front of the first rib. The indications are upper extremity CRPS, sympathetic pain of head and neck, random limb pain, acute herpes zoster pain, post-herpetic neuralgia, pain secondary to neoplastic infiltration, Paget's disease, arterial embolism, venous insufficiency, frostbite. Splanchnic block. Splank, we have to remember the splank. Actually, most of the times people use splanchnic block and celiac plexus block as a similar terminology, but they are different. We have to remember that. And the crura of the diaphragm, it differentiates between the two. If we are posterior to the crura, then it is splanchnic block. And if we go anterior to the crura, then it is celiac plexus block. We perform the celiac plexus block at T11 level with thoracic vertebra, 11 thoracic vertebra. And the indications are pain syndrome involving upper abdominal viscera, acute and chronic pancreatitis, cancer pain from upper abdominal viscera. These are the pictures showing the difference between the celiac plexus block and splanchnic block. These two images are of celiac plexus block and these two are of splanchnic block. This is a image showing celiac plexus block, posterior anterior view of both the needles with needle tip at the level of intradiscal space between T12 and L1. Celiac plexus block is performed at L1 level or T12 or L1 level, and the splanchnic is performed at T11 level. The celiac plexus block lateral view, both the needles, these are seen, they are not clearly visible, but you can see both the needles are visible. And in splanchnic block, this is T11 vertebra, and you can see the needle and the dye spread along the T11 vertebra. And in lateral image, you can see the dye spread along the anterolateral border of the vertebra. This is again, these are the images showing celiac plexus block. Hypogastric plexus block, it is performed at the junction of L5 lumbar vertebra, lower part and upper body of the S1 vertebra, upper part of the body of the S1 vertebra. The indications are intractable pelvic pain from the cancer and any other benign conditions such as chronic epididymis, prostatitis, pelvic inflammatory diseases, endometriosis, adhesions, etc. Ganglion impar block, it is a solitary retroperitoneal structure located at the level of sacrococcygeal junction. The paired sympathetic ganglion terminates here. The indications are intractable perineal pain, neoplastic neoplastic etiology with manifestation of sympathetically mediated pain, burning, ill-defined perineal pain, urgency, and the contraindications being infection, bleeding, disorders, uncooperative patient. The advanced interventional procedures are trigeminal nerve block at ganglion or branches, glossopharyngeal nerve block, celiac plexus block, spinal cord stimulation. And this is a picture showing the spinal cord stimulator implantation. Vertebroplasty for compression fracture of the vertebra. It is again an advanced procedure. Intrathecal drug delivery system. These are the constant flow rate pump and programmable pump. So these are the evidences.
There's a lot of disturbance behind. There's a lot of disturbance behind.
Intraluminal corticosteroid administration, it has evidence of 2B plus. Transforaminal corticosteroid administration in contained herniation, it has got evidence of 2B plus. Transforaminal corticosteroid administration in extruded herniation, 2B minus. Radiofrequency regioning at the level of spinal ganglion, that is DRGs, 2A minus. Pulse radiofrequency treatment at the level of spinal ganglion, 2C plus. Spinal cord stimulation in failed back surgery syndrome only. The evidence is 2A plus. And adhesiolysis by epiduroscopy, the evidence is 2B plus minus. So these are the different, this is the article showing different guidelines for the interventional pain procedures. So why pain clinic? We can find out the exact cause of pain with different diagnostic blocks and which gives immediate pain relief. Most of the time surgery can be avoided. Patient does not need hospital admission. Most of the procedures are daycare procedures. Patient does not need long-term rest and can resume work in 2 to 3 days. Patient's working capacity is increased than previous one. Requirement of NSAIDs and other analgesics is reduced drastically. So the side effects because of them are reduced. Patients who are not fit for surgery and anesthesia can get maximum benefit. Patient needs such treatment. If patient needs such treatment in future, it can be done safely. Thus, patient's psychological, physical strength is achieved and improved, and the patient can live life to his optimum. Thus, chronic pain is one of the most underestimated healthcare problem in today's world. These are the different articles for people who are interested to take pain medicine as a career. Teaching and training in pain medicine, there are various fellowships which are available inside our country or outside. 1-year fellowship and certificate courses in pain medicine at BHU Varanasi, SGPGI Lucknow, Maharashtra MHS University, D.Y. Patil Medical College Nehru, DM in pain medicine in AIMS Dehradun. These are the different fellowships again available in India and abroad. National Board of Examinations, New Delhi, has approved and notified Fellowship National Board FNB in pain medicine in 2020. So the goal of pain physicians and pain clinic is to identify the source of pain, to ease the pain, find out the cause of patient's pain by different simple diagnostic tests, eliminating pain using medical and non-surgical interventional treatments. Thus, major surgery can be avoided to help patients to manage their pain and resume their normal productive life. So to summarize, we need more exposure, clinical exposure, we need training, we need more teachers, we need research, and we have to establish pain medicine as a super specialty, and we get blessings from the patient. Thank you so much.
Sejal?
Yes, madam. We are moving ahead to our discussion part. If anyone has query, you can put in chat box.
We can't see any queries in the chat box. Anyone who would like to verbally ask any questions? Can you unmute yourself and can ask the questions to the speakers? Okay, I think we would like to conclude our webinar today on pain management. Sejal, would you like to give a vote of thanks?
Yes. We extend our vote of thanks to our speakers today, Dr. Varshali Kenia madam and Dr. Asha Barge madam, for such informative lectures. It has definitely added to our knowledge, madam. I would also like to thank MSCISA for providing the Zoom platform. I would like to thank Akhilesh Kulkarni and Varsha from Jenica Tech for technical support. I would like to thank Dr. Manisha Katikar madam, President MSCISA, and delegates from all over the Maharashtra who attended the webinar by sparing their valuable time. We conclude the webinar here.
Thank you, everyone.
Thank you, Nivargi madam. Thank you, Katikar madam. It was a pleasant attending the meet. Thank you.
Yeah, we too enjoyed your speech as well as, just a minute.
I'm very sorry I lost the internet connection in between.
It okay,
So-
it happens. No problem. We
Yeah.
will connect it again within a short period of time. That was good.
We enjoyed talk of both the speakers, Varshali as well as Asha madam. It was really nice presentation. Sorry for
Yes.
disturbances from my side just now even.
Thank you, Manisha, for joining.
Thank you, Kavita.
And-
Thank you. It was my pleasure.
Thank you. Thank you, dear.
Thank you,
Thank you,
Manisha madam.
everyone.
Thank you.
Bye.
Conclude the webinar here. And thank you, everyone, for joining and participating. Okay.
Thank you.
Thank you. Good
Thank
night.
you so much. Thank you so much. Shall we leave?
I think we can. I think we can. Yes, Asha, you can. Okay.
Thank you, Nivargi madam. It was nice meeting you
Thank you, Dr. Varsali.
virtually.
Yes, we will meet soon.
Yes.
You
Hope
are
so.
coming for our CME in August.
I haven't got any idea of
No,
that.
no, we
CME,
have,
no.
yeah, no, we
Yeah,
have
you
just-
haven't.
Yeah, in the
Okay.
process. We have not yet put up on the board, the same platform, but we are in the process.
At Solapur?
Yes, yes, Solapur.
Yeah, it's my in-laws' place. So no
Definitely
problem
do
in
come.
coming.
Definitely do come.
Sure. Yeah, sure. Okay. Good night.
Good night.
Good night, Asha. Nice
Good night.
presentation.
Okay, bye.
Bye.
I will talk to you after some
Yeah,
time.
yeah. Yeah. Bye.
Bye-bye. Thank you, Agarwal madam, for joining.